Sir, sir. Start చేసా వస్తుందండి సో థ్యాంక్ యూ. Hello class, good morning. Today we will be talking about CA breast. Last time I discussed about gynecomastia. Gynecomastia per se does not cause CA breast, but yes, whenever Klinefelter syndrome is there, XSY, the chances of patient developing CA breast are quite high. So if gynecomastia is there, patient should have Klinefelter syndrome for him to develop CA breast. Okay, now let's come to CA breast proper. The most common cancer in women across the globe is CA breast. Okay, the most common cause of death is lung cancer, both in male and female, but in female it is CA breast that is the most common cancer. So you should remember these both points, right? Upper outer quadrant is the most common site of CA breast. Upper outer quadrant is the most common cause of CA, most common location of CA breast. In about 60% females develop CA breast in this region, and about 6% of them, which is the lowest incidence, lower outer quadrant of the CA breast. Lower outer quadrant is the only about 6% people develop. And now we'll come to etiological factors of CA breast. Now we have to see the most common factor in etiological factor of the CA breast is age of the female. Okay, now we should remember what are the things that can be modified to prevent CA breast, what are the things that cannot be modified. What can be modified? If we modify and apply it in our life, it is helpful, otherwise it is not. So now we'll talk about what are the modifiable causes of CA breast. First is non-modifiable causes of CA breast. Age is the most important thing. As your age keeps increasing, the chances of you developing CA breast is quite high. And female sex, it is the most common problem that is happening in the female. So female sex, these are the things that cannot be modified. Then early menarche, less than 12 years of age, and late menopause, greater than 50 years or 55 years. Some books say 55, some books say 50. So greater than 50 years menopause. So that is the period, menarche and the menopause, that is the period within which the lady is actually having a lot of estrogen exposure. Okay, that is the period that cannot be modified. Then family history of CA breast is one of the reason that cannot be modified. Then you should remember that BRCA1 and 2 genes, if present in a lady, the chances of her family relatives developing CA breast are quite high. Race and ethnicity, whites usually develop CA breast more common. So race and ethnicity, both of them are non-modifiable causes. And then history of radiation exposure. If a lady has already got exposed to radiation, there's no chance that we can modify that anymore. We can't do that, right? It's already happened, so we cannot modify. Now what are the modifiable causes of CA breast? Reproductive age. Okay, anybody who has the first child at the age of 30, the chances of CA breast are quite high. Parity, if the woman is multiparous, the chances of she developing CA breast decrease, whereas if she is nulliparous, the chances are high that she will develop CA breast. Absent breastfeeding, because when you breastfeed, the patient will have lactational amenorrhea. If there is no lactation, if you don't breastfeed, that is what happens in nulliparous. That period of amenorrhea is not there, and the chances of you getting exposed because you develop your menstrual cycle. So this will happen. Absent breastfeeding is one of the reasons for developing CA breast. Obesity is modifiable. You can lose weight. Tobacco. You can stop smoking. If you don't want CA breast, you can stop smoking. Alcohol, you can stop taking alcohol. So these are all modifiable causes of CA breast. Night shifts, if you stop doing night shifts, no CA breast. If you decrease exercise, you will have CA breast because you become fat. If you're obese, the chances of you developing CA breast are quite high. Hormone replacement drugs, these, yes, you can only take progesterone only pills, but when you take OCPs with estrogen dominance, the chances of developing CA breast are quite high. Then there are histological risk factors also for CA breast. That is proliferative breast diseases like atypical ductal hyperplasia, atypical lobular hyperplasia. Both of them tend to cause CA breast. So you have to see histological pattern, what is happening, and then lobular carcinoma in situ. Both these are all histological factors. Now we'll come to incidence of breast cancer syndrome. Sporadic breast cancer, that somebody developing just like that, is about 65 to 70%. Familial breast cancer is about 20 to 30%. Sporadic is about 65 to 75%. Familial breast cancer is 20 to 30%, and hereditary breast cancer is about 5 to 10%. And what are the effects of hereditary breast cancer? BRCA1, about 45% of them will develop CA breast in their lifetime. About 45% of them. BRCA2 will also cause breast cancer in about 35%. P53, that is Li-Fraumeni syndrome, less than 1%. Peutz-Jeghers also is less than 1%, but Peutz-Jeghers, Cowden's disease, Muir-Torre syndrome, ataxia-telangiectasia, these are all account for less than 1%. Altogether account for less than 1%. Now we'll have to remember about two important factors, that is BRCA1 gene mutation, which happens on the long arm of chromosome 17, BRCA2 gene mutation, chromosome 13q. So these are very important. BRCA, without BRCA, whenever breast cancer is there, without BRCA, probably the paper will not be there. So whenever you have a BRCA1 gene mutation, usually the cancer is poorly differentiated. Invasive ductal type, it is usually invasive ductal type. Hormone receptor is usually negative. We want ER/PR to be positive, but in case of BRCA1, the hormone receptor is negative. Associated with ovarian, prostate, and colon cancers. Whenever BRCA1 is there, you have it associated cancer syndromes, that is ovarian cancer, prostate cancer, and colon cancers. BRCA2 on the other hand, basically it's well differentiated cancer. It is 13q, long arm of 13q, express hormone receptors associated with ovarian, colon, prostate, pancreas, gallbladder, bile duct, stomach cancers, and also melanoma. Increased risk of CA breast in men also is seen in BRCA2 gene. Lifetime risk factor of cancer breast in BRCA1 is about 60 to 70%, and lifetime risk of ovarian cancer is about 40% in BRCA1. Whereas in BRCA2, it will increase up to 85%, and lifetime risk of ovarian cancer decreases to 20%. decreases to 20%. In BRCA1 gene mutations, you have increased chances of patient developing basal file breast cancer. Then there are some mutations of Herceptin 2 mutation, that is ERB2, transmembrane growth factor. Okay, transmembrane growth factor. In these patients, you develop invasive breast cancer, and most of the times, in 80% of the times, it is ductal carcinoma variety and usually carries poor prognosis. And then P53 mutation, I already told you about Li-Fraumeni syndrome, is also associated with poor prognosis. And these P53 mutation, the problem is whenever P53 mutation is there, they don't respond to chemotherapy. Now, some books say smoking and oral contraceptives by young women have increased risk of breast cancer. Okay, OCP takers have risk of breast cancer and as the risk decreases as the year increases. Then combined HRT with estrogen and progesterone increases the risk factor of CA breast to about 20% in 5 years. Estrogen only pill, okay, previously was thought to have increased risk of CA breast, but right now it is over a period of time becoming obsolete concept. Okay, then reproductive risk factors: parity, lack of breastfeeding, alcohol, tobacco, HRT, decreased physical activity, night shifts of work. So all these are modifiable risk factors. We already discussed. Now there is something. Moderate exercise and lactation decreases the risk of cancer breast. Okay, decreased menstrual cycle periods by means of lactation also decreases. I already spoke to you about all this, but I'm trying to repeat. Radiation exposure will increase CA breast. Risk assessment of cancer breast is done by Gale system of scoring model, Gale model and Claus model. I already told you about Gale and Claus model in the starting of my class, based on various risk factors of CA breast. Gale and Claus model. First degree relatives, that is mothers, sisters and daughters of patients with breast cancer, have a twofold to threefold rise of risk of breast cancer, that is seen in about nearly 13% of CA breast. Nearly about 13% of the CA breast. Now we'll come to types of CA breast. There is basically two types. Okay, carcinoma in situ ductal variety, that is DCIS, and lobular carcinoma in situ LCIS. And these will move and become invasive carcinoma of the CA, invasive carcinoma of the breast. Number one, lobular carcinoma in situ. It is seen only in females. Okay, it's seen only in females. Most of the times it is bilateral and multicentric. In the same breast, it could be in 2 to 3 places. Okay, it is multicentric. Increased risk of invasive cancer in both the breasts. Histological feature of lobular carcinoma is tumor cells invade in linear pattern, that is Indian file pattern. Okay, commonest clinical factor of breast of LCIS is breast mass with an ill-defined margin, usually presents as an incidental finding. It's usually found incidentally on palpation or mammography. Most of the times it is a mammography pickup. Usual age group is about 45 to 50 age group. Then most commonly seen in women. Mammography shows the adjunct, the side tissues showing calcification, Tumor proper will not show calcification. It is called, the word is called as neighboring calcification. It's called as neighboring calcification, and this neighboring calcification is a unique feature of lobular carcinoma. Unique feature of lobular carcinoma. Unique feature of lobular carcinoma, that is about LSC. It's an Indian file pattern. Indian file pattern is the Red Indians in the old day, they used to move for war. If they're going, they used to go in a single line pattern. That is why it's called as Indian file pattern. Okay, what is the treatment that you give? You give 3 options to the patient: observe, screen regularly, and excision by bilateral simple mastectomy. Excision by bilateral simple mastectomy. One type of LCIS, that is pleomorphic LCIS, is quite aggressive, is very aggressive type. So pleomorphic type shows calcification which can be seen on mammography, and basically it should be treated as with excision immediately. Excision immediately. Now, multicentral and multifocal. Multicentral, presence of multiple tumors within one quadrant of the breast is multifocal. Okay, presence of multiple tumors in different quadrants of the breast is multicentric. Multicentric. That is, you should remember, it is a feature of lobular carcinoma in C2. Lobular carcinoma in C2. 4 types of DCIS are there. Now we'll come to ductal carcinoma in C2. This is what becomes invasive ductal carcinoma. So 4 types of DCIS are there. That is papillary variety, cribriform variety, solid variety, and comedocarcinoma. Solid variety and comedocarcinoma. Low grade lesions are papillary and cribriform. Okay, first 2 are low grades like papillary and cribriform, whereas high grade are solid and comedo. Segmental calcification, clustered calcification. These both are seen in mammography findings of DCIS. Microcalcification and mammography are classical findings. Treatment options for DCIS are mastectomy is advisable. Indications for mastectomy in DCIS are diffuse microcalcification suggestive of extensive disease, inability to obtain clear margin, poor cosmetic result after resection, patient not motivated by BCS, and contradiction to radiotherapy. These are the indications for mastectomy. Okay, then breast conservative surgery in DCIS also can be done, that is lumpectomy plus radiotherapy. Okay, then there is something called as Van Nuys grading. I already told you about it. Is used to decide whether RT can be avoided in selective cases after lumpectomy. Now, Van Nuys favorable cases for whom RT can be avoided are low and intermediate grade DCIS, that is less than 2.5 centimeter size, and minimum margin is 1 centimeter after excision. Role of tamoxifen in DCIS, reduction of CA breast is same in BC, and 5 to 10% in DCIS and LCIS, and finish off today, and then we'll start invasive CA breast later on. Okay, then mammographic signs, none, whereas calcification is seen in DCIS. There is a surrounding calcification in lobular carcinoma. Multicentricity is seen in lobular carcinoma in C2, that is 60 to 90%, and multicentricity is seen about 40 to 80% in DCIS. Bilaterality is 50 to 70% in lobular carcinoma and 20% in DCIS. Subsequent invasive carcinoma increases in both, and histology of invasive carcinoma, ductal carcinoma, thus the subsequent invasive carcinoma that develops in 65% ductal origin type and not lobular type. not lobular type. Yeah, in the next class I'll be continuing with invasive CA breast. Okay, bye.